de la pantalla abajo de la pantalla de el Zoom van a encontrar algo que se llama subtítulos. Poner subtítulos, agregar subtítulos o algo así. Entonces, le tienen que configurar que el idioma que se está hablando es el inglés, idioma hablado inglés, y el ajuste de subtítulos le tienen que seleccionar a español. ¿Sí? Esperemos que todos puedan ponerlos. Entonces, ustedes van a poner en donde dice agregar subtítulos o configurar subtítulos, le ponen que el idioma hablado es inglés y solito les va a empezar a traducir. Entonces, si ya nadie tiene una duda, vamos a empezar. Ahorita que empiece a hablar Mary, por favor, me confirman si todos entendieron esa parte de los subtítulos y ya se ven. Okay, so Mary, I think we are ready. I already explained them how they can put the subtitles if they need to. So I think we are ready for you to start.
That's really exciting that it can do subtitles. I hope it works. Technology is amazing. Yay. And you guys can see my screen. Yes. See? Yes. Okay. And so tonight I'm talking with occupational therapy students. And is that right? And physical therapy students or just occupational?
Yes, both.
Both. Okay. And so this is going to be evaluation of the hand, wrist, and elbow. It's going to be more orthopedic oriented as opposed to neuro. And these are just some resources. And when I talk about evaluation techniques, I'm using the techniques, a lot of them from this assessment of the hand from the American Society of Hand Therapists. In orthopedics, and there's so many abbreviations and it can be very overwhelming. So I've got some of the common ones listed here. So don't worry about memorizing everything. Just know that you have this list that you can come back to. So I thought I would start with some anatomy, and I would encourage you guys to try to find these things on yourself as we go through it. And everyone is at their home, right? They're joining us from their home. They're not in a group. Okay. So we'll just quickly run through some anatomy. I know you've had it in your classes, but it's a little different finding it on yourself. And of course, everyone knows the olecranon, and that's the ulna, part of the ulna. And proximally, the ulna is the bigger bone, and distally, the radius is the bigger bone. And the force is transmitted through the interosseous membrane from the radius to the ulna. And what we call just the muscles, the extensor muscles, we call that the mobile wad because you can grab it and move it around. And this is the olecranon, it's the ulna. And on each side, these are the epicondyles. And this would be the medial epicondyle and the lateral epicondyle. And those are the epicondyles of the humerus. And if you go to the medial epicondyle and the olecranon, if you go in between, that's called the cubital tunnel, and that is where the ulnar nerve is. And if you tap on it, you may feel some electricity going out like this. Then if we go over to the lateral side, we have the lateral epicondyle, and that's something you're going to see a lot of. You're going to see a lot of people who have lateral epicondylitis, and you may get it yourself depending on what you do. All the extensor muscles attached to the lateral epicondyle. And then coming off the lateral epicondyle is the radial tunnel. And you won't really feel it on a patient, but if you push on your own arm, you'll feel where it's very tender. And that's how you know you're on the radial nerve. One way to palpate the superficial flexors is to take your other hand, the thenar eminence of your other hand, and just place it on that medial epicondyle. And where your fingers fall, that's where the flexors are. And you don't really think about it, but the flexors all pull towards the medial epicondyle, and the extensors all pull to the lateral epicondyle. Maybe we sort of think of them as going straight, but they really pull to the different epicondyles. And if you go to your ulna here and push in with your fingers and then make a fist, you'll feel that's where those flexors are. So they're really not as, maybe not as volar as you think, the flexors. So we have in the back of the hand, we have the dorsal compartments, and we're going to talk about those a little bit more. But the first dorsal compartment is here. And one way to find it is to abduct your thumb, and you'll see that EPL, extensor pollicis longus. And it does the border, the EPL, and also the two extensor tendons here. And in between that is the anatomic snuff box. And we're going to talk about that a lot when we talk about evaluation of the hand and evaluation of thumb pain. And one way to kind of find the carpal bones is if you flex your wrist, and again, you'll see it more in people who have maybe older hands, but you can sort of see the dimple there. And that's a good landmark. So that's sort of in between the capitate distally and the lunate proximally. So if you want to try to palpate the lunate, that's a good way to find that. The trapezium is the carpal bone that articulates with the thumb. So the thumb is called the carpal metacarpal joint, and it's the carpal bone trapezium articulates with the first metacarpal, and that's the base joint of your thumb. And then there's the radial styloid. And you know, the radius, distal radius looks like this, and that's the radial styloid. So it's right here. So if you're touching the radial styloid, when your finger moves, when you do radial ulnar deviation, your finger will stay in the same place. And if you're out on the trapezium, then your finger will move. So that's how you know when you're out on it. This is a picture of my hand, and you can see the dimple, and so you know the capitate's the bigger bone, distally lunate's the bone proximally. If you touch the dorsum of your radius, you'll find a bump on that, and that's called Lister's tubercle. And one way to find it is if you radially abduct your thumb and follow the EPL, it'll lasso around Lister's tubercle. So just a way to find that. Another important thing to find is the hook of the hamate, because underneath the hook of the hamate is where the ulnar nerve is, and we're going to talk a lot about the ulnar nerve. So you can pretty much find the pisiform. It's a little bone here. Pisiform is like a P, and you know you're on the pisiform because it moves around. It's a sesamoid bone, and it moves around in the flexor carpi ulnaris tendon, the FCU tendon. So if you go pisiform and then you go distal and radial right here, you're going to find the hook of the hamate. And again, if you have good muscles, it'll be harder to find. And on someone like me, it's pretty easy to find. But if you push down on there, you're going to feel a hard, kind of like a little P. And it'll be uncomfortable because you're pushing on the ulnar nerve. And that's the ulnar nerve. It's called Guyon's canal there. So really important. This is the ulnar styloid, more prominent on some people than other people. And a way to find the scaphoid, which is a really important bone, and we're going to talk about it a lot, and we talk about testing, is if you flex your little finger, it'll kind of point to the tuberosity of the scaphoid. And then once you think you're on it, go into ulnar deviation, and it kind of goes away. And when you go into radial, it pokes out. So that's how you know you're on the scaphoid. And again, some people's are more prominent than others. We're going to talk about the dorsal compartments and the CMC joint. So the first CMC joint is the most mobile joint, and that's the base joint of the thumb, very mobile. The second CMC joint for the index finger and the third don't really move, but the fourth and the fifth move. So this is my wrist flexing, but this is my fifth metacarpal. You see the fifth metacarpal moves quite a bit. So that's wrist, that's fifth metacarpal. And we're going to talk about that a little bit more. So the fifth metacarpal moves about 30 degrees and the fourth moves about 15. And then the second and third are fixed units, and the first is the thumb joint, and it moves a lot. So the volar anatomy, we have the muscles of the thenar eminence. They're here, and you didn't really think about that. That's a muscle belly. We have the muscles of the hypothenar eminence. The thenar are innervated by the median nerve. Hypothenar are innervated by the ulnar nerve. And then we have a ligament that comes across here. And this ligament helps keep the tendons close to the bone. And if you look at the flexor tendons, they all come into the hand together. So they come in as a bunch underneath this ligament, and then they spread out to each finger. And they come in under this ligament, and that's called the transverse carpal ligament or the flexor retinaculum. And the space underneath it is called does anybody know? Carpal tunnel. And if you have a carpal tunnel release, that's the ligament that they cut. And so just some more volar anatomy. We have the pulleys, and these are important for trigger finger, and we're going to talk about them a little bit more. So we have two flexor tendons. We have one that flexes all three and one that just flexes the MP and the PIP. So the one that flexes all three, it's called the flexor digitorum profundus. So we would say you can remember it by saying it's profound. It can flex all three. And the superficialis only flexes the two. Well, one interesting thing is that the superficialis has independent muscle belly. So you can flex each finger. The flexor digitorum superficialis can flex each finger individually. So if your hand is straight, you can just flex your index PIP, just your middle PIP, just your ring PIP. But the profundus that flexes all of them and it flexes the tip, it has to move together. So you can't just flex one tip. You have to flex them all. It works together. And when a muscle has to work together, it's called a quadriga muscle. And quadriga just means four. It means the four of them have to work together. So if you do it to yourself, make a fist, and now hold one of your fingers straight and make a fist, and you'll see you can't make a full fist. They have to come together. And I think that's something really important to remember. When you flex your fingers, they all point to the tuberosity of the scaphoid. So remember, if you're stretching someone's finger, the little finger doesn't go straight down. It goes to the middle. And do it yourself. It's uncomfortable to go that way. Remember, it goes to the middle. Then another interesting thing is that the sole flexor of the distal phalanx of the thumb, the muscle that flexes this, well, it's actually connected to the profundus, which is the muscle that flexes the tip joint. And it's actually, who knows how many people, it's estimated anywhere from 13% to 70%. That's a pretty wide margin of people who it's affected. I would say it's closer to 70 based on the people that I've seen, but everybody do it. So keeping your finger straight, take the tip of your thumb and go all the way here to the distal palmar crease under the small finger. And see your fingers bend? That's because these two are connected. So when this one pulls, it pulls those two. Just an interesting little fun fact. So some more anatomy, the dorsal compartments. So remember we talked about the flexor tendons all come in together. They come in the middle together, and there's the ligament called the flexor retinaculum that's there to hold those tendons in place. Well, on the back, if you look at the extensor tendons, they all come in separately. And so the ligament, the extensor retinaculum, is actually longer. It comes all the way around, and you can see the extensor retinaculum here. Can you guys see my arrow on the slide?
Yes.
Yeah, okay. So that's the extensor retinaculum. And if you didn't have that, when you went back like this, your extensor tendons would be hanging out here like a bow. So on the flexor side, the ligament just goes straight across. But then on the extensor side, since they're all spread out, the ligament actually tucks in between the groups of tendons. And when it does, it makes a small space. And so where it tucks in, those are called the compartments, the dorsal compartments. So the first dorsal compartment is here. And the sixth is here. And there's the third. And usually the only one that you really need to know about is the first dorsal compartment, because that's where you get a tenosynovitis, a common tenosynovitis. And the sixth, many times people will tear that ligament there. But you may, or your instructors may or may not have you memorize those dorsal compartments. So we talked about the profundus being a quadriga muscle, that if you flex the tip joint, they all have to work together. Well, the other quadriga muscle is the extensor digitorum communis, EDC, and it has to work together. So its job is to extend the MCPs. That's the EDC, and it extends all of them. And again, it has to work together. But in addition to, all the fingers have the EDC, but the index finger also has its very own extensor, and the small finger has its own extensor. So the index finger, you can point like that and have the index finger straight. But if the other fingers are flexed, you can't completely extend your middle finger, because for those, they all have to move together. Another muscle that's pretty important that we'll talk about a lot is the adductor pollicis, and that's here. So if you adduct your thumb, you'll see that's a muscle belly.
Mary, they're
Yes.
saying that you're going a little bit too fast.
Oh, okay.
Yeah.
I'm
I'm
bad about that.
Yeah, a little bit slower. So,
Okay.
yeah. Thank you.
Awesome.
Oh,
Dile a Mary que nos permita un segundito. Voy a decirle unas cosas. Lupita, permítanos un segundo, chicos. Lupita, ¿puedes dejar de grabar, por favor, para que lo grabe? O sea, terminar la grabación para grabarlo yo, porque a mí sí me aparece en español, esperando que se graben los subtítulos en español.
okay.
Okay.
Mary, you wait a little bit so they can change the recording, so Vero can record it in